here is your chance. Yes, it's something that is not only a serious health issue to us, but it's also a social and public health safety issue, and that affects all of us. When we look at the statistics, what we see is that women are at risk of sexual violence almost all their life, or at every point of their lifetime. While for the men, they are greatly at risk of sexual violence as children and through their adolescence. That is right from, well, you would say as a neonate, because we know for sure that even babies can be, sexually violated, all through up to our teenage life. When they become adults, their risk goes down. That doesn't mean that they cannot be sexually violated, but the risk goes down. Now, over 90% of the people that are sexually violated do not report these cases for various reasons. Shame, they feel humiliated, embarrassed. Some don't know where to go, while others feel they may not be believed when they say their story. And also for others, unfortunately, this is done by people that we know, our employers, our family members, people who are supposed to protect us, or people that we trust. And therefore, we don't know what will happen. We might complicate the relationships, we might lose our job. And so we keep quiet. Now, what do we as people do? Many of us take the bystander role. It's not my business. I might make things worse, so let me just stay out of it. For some of us, unfortunately, we just don't know what to do. And as health workers, we have a lot of influence in our communities and a lot we can do to actually help and support the victims of sexual violence and the trauma that they face. And this is why we are having this session, because it's important for us to have practical sessions on how best we can contribute and help these victims. And in our session, we have seasoned experts on this topic who will be discussing different aspects of that topic with us. We have our case presenter. Before we start the discussion, we are going to have a case presented to us, a real life experience. And this is going to be given by Dr. Ssennyojo. We shall be giving his details later when it's his time to, but since it's the first one, Dr. Ssennyojo, you're very much welcome.
Thank you.
He's a medical doctor and also a section reproductive health specialist working with Reproductive Health Uganda. On our panel still, we have another expert, Dr. Ruth Babirye. You can wave to the, yes, there she is. She's a specialist in obstetrics and gynecology and also the director of BMAMA. So BMAMA is a pregnancy care center. Please feel free after here to get her contact and reach out for pregnant services. Again, on our panel, we have Dr. Racheal Kwagala. He's an emergency medicine resident at MakCHS University, College of Health Sciences. Dr. Kwagala will be responding to most of the chat questions that you'll be having. And still on our panel, we have another expert, Ms. Racheal Wenene, who is a section reproductive health specialist. And she's working with a Women First digital solutions. So this is a platform that offers digital solutions to section reproductive health issues. In case that's an area you're interested in, feel free to reach out once again. And lastly, but not the least, on our panel, we shall have another expert, a seasoned clinical psychologist. That is Ms. Joy Gumikiriza Onoria. She's a clinical psychologist and a lecturer at MakCHS University, the Department of Psychiatry. She'll be online. She's not here physically, but she'll be online to discuss with us the psychological aspect of sexual violence. Now, before we start our session, we are going to share with you a link in the chat. I kindly request that you open that link. It has pre-test questions. These are questions we want to know, to assess just slightly, to just know what you know about sexual violence and gynecological trauma. And at the same time, I would like you to post in the chat what your expectations of this session are. What do you expect to learn? What would you like the experts to talk about? And we shall give a few minutes for that, after which we shall come back. The questions are within the chat. Kindly participate It will take us about 5 minutes, and then we shall end the poll. Yes, thank you for participating. Kindly continue participating. And as you do so, also type in the chat your session expectations and objectives for this session. What do you expect from this session? Feel free. Now, if you feel that for you, you want to speak, or you feel you would better express yourself vocally without texting, kindly raise your hand. We shall be able to see your hand raised, and we shall give you a minute to share your expectations. We shall give about 2 lucky people a chance to speak to us about their expectations. Niwamanya David has put up their hand. Okay.
Yeah. Yes, hello.
Yes, I see that your hand is up. Kindly share your expectations of the session.
Okay, thank you. My name is David. I'm calling from Gwyn Community Hospital, Kanong District. So
great.
my expectation is one, I would like to know from the team of experts, how to manage these cases of violence, most especially to the adolescents, because we have had these cases and we are always facing challenges in the management. And then the other expectation I would need to meet by the end of this session is how to know the referral system, most especially beginning with the local system, or can say beginning with the place where the assault, where the sin, at the place of sin. Because the challenge here is, for example, we've had challenges whereby a young child is raped, but instead of the team first running to the hospital, they have to first go to the police, then they delay for that time of PEP, and now the whole situation becomes worse. Thank you so much.
Thank you very much. Thank you very much, David. And we are so happy that even in Kanung, you're able to actually log into this session. That's great. I am going to give to another chance to Tumanye Samson. Kindly,
yes, thank you very much. My name is Tumanye Samson. I'm in Guru at Guru Regional Referral Hospital. I would like the team of experts to guide us on how to fill those legal forms, the police forms for those people with defilement cases, those HGBV cases, how to fill a police form and collect samples for the victims. Thank you.
Thank you very much to Manye. How to fill a police form and collect samples. Okay, one person that has been persisting go through, Stephen Imbuga. This is a very last one. What are your expectations?
Okay, thank you very much. Okay, I'm Mbuga Stephen, a clinical officer. I'm working in a private facility in Kayunga, which is Matovu Medical Center. Now, I'm expecting to talk about this rare case. We know that most common time sexual violence is where one party has been forced or has been actually not willing to participate into the violence. We always get cases, most of the young girls in age of 16, 17, who willing like participate these actions. And to the definition, these are still underage people, which also goes sexual violence. So I always get problems with them. When I'm filling the form, you know how they have to bring the information. They always keep some information.
Stambuga,
So how
kindly
better to
repeat
handle
your
those
question.
people? Thank you very much.
Could you summarize your question in one sentence?
I always get problems when I'm interacting with these people, like young girls of age 17, 16, they are willingly participate into a sexual act.
Okay.
Yet they are still underage. I also believe that is also sexual violence. So how better can we handle these people? Relevant information which we need from them. Thank you.
All right. Thank you very much. Thank you. Thank you all for participating, including those that texted in the chat. Your expectations have been noted. And by the end of the session, we believe that most of them will have been addressed. Without wasting more time, let me invite Dr. Ssennyojo to share with us the case. You're very much welcome, Dr. Ssennyojo.
Thank you very much, Dr. Lillian, colleagues in the house, and those that are joining us online. Good afternoon. My name is Dr. Racheal Ssennyojo. I work with Reproductive Uganda as a service provider in charge of a part branch, but I'll be shifting to Kampala starting from next week, so you can link me up. Our case today, the case that will guide us in the discussion, and we are going to proceed. Our patient is AJ. She's 14 years old. I didn't put the address intentionally, but the next of kin is AS, who's the mother. She's a Catholic and she's in primary 5. AJ presented to our facility with vaginal bleeding and low abdominal pain for 4 days. The history of presenting complaint, AJ presented on the 24th of November 2023 with low abdominal pain and vaginal bleeding for 4 days, following rape by a close relative. The victim reported to have been invited by a brother at his house, who then forcefully raped her with intimidation, not to tell anyone if she was to remain safe. She also reported that no protection was used in the act, and she sustained several injuries in her genital area. The second day following the incidents, she noticed that the abdominal pain was intensifying and the vaginal bleeding was not reducing. So she actually informed her mother a day after the incident, and the mother took her to the nearby clinic in the village. Upon the examination, the nurse was in the clinic, gave her a painkiller, and then advised them to go to police. And then after that, proceed to a better place for management. However, they didn't go to the police and came to Racheal Kwagala a day after they were being referred from the clinic. On arrival, the receiving service provider advised them that after the management, they should still go and report the case to the police. But the mother of the victim insisted that she had no intentions of reporting the case and requested the service provider to go ahead with the management. On the review of other systems, nothing was remarkable. There was nothing in the medical and surgical history. And the gynae history, she had a menarche at 13 years. Her normal menstrual period, the last one was on the 4th of November 2024, and she had never had any sexual encounter. The victim stayed with the mother, who is a single mother. There are 3 more siblings. She's the firstborn in primary 5. The mother is a peasant farmer in the village, and she's the breadwinner of the family. And the family stays within the same location with the perpetuator. When we proceeded to the examination, this is what we found on the general exam. The victim was anxious and appeared to be in extreme fear, and she was really unresponsive to most of the questions as we're taking some history. And she also appeared young for her age of 14. However, she was dressed in plain and soiled clothes, didn't have any visible wounds or bruises or any injuries on the parts that were exposed or uncovered by the clothes. Further examination was mildly pale, and the vitals, as you're seeing them, the blood pressure was 102 out of 61. She was a bit anxious, but the pulse was 80 beats per minute. The respiratory rate was 18 breaths per minute, and the temperature was 36.4 degrees. On the systemic exam, there were normal findings on inspection of the abdomen. However, on palpation, we noted marked suprappubic tenderness. And then we proceeded the genital exam. We noticed that she had a pad on, but it was heavily soiled with blood. The external genitalia was visibly soiled with blood as well. And the labia were edematous. However, we didn't notice any semen, maybe foreign particles that could identify maybe the source of the injury. That picture there is a bit, might not be good for some people, but I put it there intentionally to look at the victim. We took that picture with consent, but we cut out any other feature that might identify the victim. So just for demonstration and learning purposes, we noticed that the client had, or the victim had a tear, a perineal tear, which was around 2nd, 3rd degree. We didn't confirm really the degree of the tear. And she had multiple lacerations on the labia. We didn't assess very well in this genital exam because she was in severe pain and she was uncooperative, regardless of the analgesia that we gave prior to the examination. We did some investigations as well. The HIV test was done, it was negative. The HB, she was a bit anemic with HB of 8.8 grams per deciliter. We also did a pelvic ultrasound scan since she was in severe abdominal pain. And the scan, those were the findings. And there were small, findings were suggestive of a small pelvic hematoma and some accumulation of blood inside the uterus. We did a syphilis test as well, just screening for STIs. And we did a pregnancy test, which was negative. There and then, we initiated some emergency treatment. We gave emergency contraception. Since the victim came before 20 hours, of recent, we consider 5 days for the emergency contraception. So she was within the period or the time frame. However, we did not initiate the HIV prophylaxis because it was already past 72 hours. We started empirical prophylaxis for STIs with ceftriaxone start dose, doxymetro, and then we referred the victim to a general hospital where the lacerations and the tear were repaired by the gynecologist under general anesthesia since they were really intense. We did some counseling for both the victim and the mother, and we also emphasized the issue of psychosocial support to the mother. Then we didn't want to just end it there. We contacted the district child protection officer in the district to hand over the case for any appropriate follow-up that might be necessary, since the mother was not willing to actually do so, for the case of, or for reasons to have justice for the young girl. Then proceeding, we did some follow-up on the victim. At 2 weeks, we saw again after a month and after 3 months. There was progressive healing of the traumatic tears that were in the genital area, and the HIV test at 3 months was still negative. However, the mother reported that the victim was psychologically unwell. The daughter was always sad since the incident that happened to her. We discussed the possibility of linking the victim and the mother to a professional counselor and a mental support group. However, this was not effective because the mother and the victim they stay in a deep village and they could not really come to town where they could access the services. Still followed up with the child protection officer of the district, and informed us that the person who raped AJ was actually arrested after a week, was tested and was HIV negative. However, the case died a sudden death. But in his explanation, he said since the perpetrator was also a juvenile because it was 17 years reportedly, that's the reason that the case was closed. So it wasn't very clear, as I put there in the brackets. So members, colleagues online, and colleagues in the House, some of the missed opportunities in this case that we realized throughout the management or from the time of the incident up to the management are the following. One, the first procedure that the victim contacted did not offer any management apart from painkiller and referral. Remember, this is a victim of rape. We don't know the status of the person who was raped. Perhaps she could have been referred for the emergent treatment, PEP initiated, STI prophylaxis initiated, and emergency contraception. However, this wasn't done. The case was not reported to the police, and the caretaker or the mother had no interest in doing so for her personal reasons. The victim presented 4 days after the incident to us, and that's when she got some hope or some real treatment. No evidence collection was done throughout the case, and by the time the victim presented, most of the evidence was already tampered with because, like you saw in the case, she was in clean clothes, she had showered already, and it was a bit hard. So the PEP was not given, like I've said, and no adequate psychosocial support was given to the victim, and the victim didn't get any justice at the end of the day. So colleagues, I know you've listened to this case, and perhaps you've identified some missed opportunities. Please, you can put them in the chat, or you'll be guided by the moderator to see how best we could have managed the case at the end of the day. So thank you very much, colleagues, and that's our case for this session.
Thank you very much, Dr. Ssennyojo, for that saddening case. I believe it was saddened, and there are a number of questions in the chat. If you have any questions about this particular case presentation, please type them, but I'm giving an opportunity to 2 people to unmute and ask their question. Okay, so in the chat, someone asked and said, are we at liberty to pronounce rape in history taking and examination? If you have a question, if you want to unmute and ask the question, kindly put up your hand. If you're not asking a question, I request that you mute your microphone. So we had a few questions in the chat. One was, are we at liberty to pronounce rape in history taking and examination? And another one was, fewer cases reach court. Is there any allowance that court gives to health workers following up these cases? Because some take so long to come to conclusion. And I have another hand up here. Let me give Andrew O'Neill. Kindly unmute and ask your question.
Good evening, Tim. Not evening, afternoon. My question is, in the down deep there in the village where the mother, maybe the parents, had forced the young girl to go for a man.
We did not hear your question well.
It will become a scenario I am saying where the parents had forced the girl to go for marriage, the young one. And here, maybe the team identified as a sexual violence, and even the victim really, they wanted it. How would I handle this case deep in the village? Because we realize services are not down there, and when they come and when you notify, you find that the parents are supporting, and also the victim is also in their side. So how would you go about with that case? Thank you.
All right, thank you very much, Andrew. For that question, we have one more, actually 2 questions, and that will be all we are taking because of time. Samson asks, what was that rape or defilement? And then we have another question from Jeffrey. It says, what was expected from the health worker in the clinic who was the first contact with the victim? Dr. Ssennyojo, kindly, very briefly, respond to those questions and then.
Okay, thank you very much. Those who have asked your questions. One, the first person asked, are we at liberty to pronounce a rape in history taking and examinations? For purpose of understanding this case, I used the terms that I used. However, this takes us back to the definition of rape, what rape is, what defilement is, what abbreviated rape is. It will be the court to actually come up with a definitive judgment. However, considering the definition of what rape is, actually, when you look into the case, because this is a minor, and I'll mention it, this is a minor, it's not just rape, it's abbreviated rape, okay? Yes. Defilement, someone also has asked about what's the difference between defilement.
No, was this rape or defilement?
Rape or defilement. This is what we call abbreviated. Is it rape, right? Abbreviated defilement, yes. Abbreviated defilement, okay? Defilement, without, sorry? Yeah. Okay. It was rape and defilement, so we call it abbreviated defilement, okay? Where the person is not forced, that is defilement, where the victim wanted, just like as how someone has mentioned it, where the mother forces the girl to get married, or the victim, or the girl actually goes into a sexual act when they are willing, okay? Yes. And what was expected of the health worker at the facility? One, we are going to hear from this discussion about the emergent management of cases of sexual violence. And as a health worker, you should know or should have at your fingertips what should be the first thing that you do when you interface with a victim of sexual assault. So I'll leave that to the experts who are going to come throughout the session. You shall learn and get to know that in details. I don't want to preempt their discussion, but the case was a bit saddening. And to wrap it up, the last question is, most of these cases do not end up in court. That was the last question. You realize that most times the victims don't get justice because the parents tend to look at the gain out of the incident. So for example, in this case, because one, the perpetrator was a relative, also the mother made a deal with the perpetrator to close off the case. I didn't want to go into that because that would be going legal, but most cases don't reach court because of those personal reasons that people have their own selfish benefits. However, we shall also hear from the discussion how best we can proceed with the legal aspect of it. Thank you very much.
All right, thank you very much, Dr. Ssennyojo, for ably responding to the questions. Right about now, we are going to invite Dr. Ruth Grace Babirye to give us an overview of sexual violence and trauma. Dr. Babirye, you're very much welcome.
Thank you. How loud do I have to be?
Thank you, sir.
Okay.
But yeah, louder than me.
Okay. Thank you, everyone. Thank you, everyone. I'm going to take us through an overview of sexual violence and trauma. I intentionally removed the word gynecological trauma for reasons that we shall see. When we talk about gynecology, we tend to just fix it to only the girl child or the women. But sexual violence can happen to anyone, and it's not only for girls, but also for men and boys as well. The one who is moving the slides, please kindly do a good job. Thank you. So we're going to take through that, talk you through the definitions. I see there's very many definitions that are coming up within the chat. The types of sexual violence, who is at risk, history taking and examination of the patient. For this examination, my other colleague will go through it in detail. And then also, what do we do with the management of a sexual assault survivor? Just an overview of that is what I will give, and my other colleagues will carry on with that. And consequences together with the follow-up of someone who has had, someone who is a victim of sexual violence. Okay. So what is sexual violence? That's what we need to know first. I don't know why it's looking a lot of things. But okay, sexual violence is any sexual act and an attempt to obtain a sexual act or an act directed against a person's sexuality using coercion by any person, regardless of their relationship to the victim or in any setting. This is by WHO 2022. Or if you go by Ugandan ways of defining it, we shall say that sexual violence is any act which violates the autonomy, that is one's bodily integrity, of a woman, a child, under the international criminal law, including but not limited to rape, sexual assault, grievous bodily harm, mutilation of female reproductive organs, among others. This is a very comprehensive definition and at least tells us that sexual violence is not just rape and defilement, but it is more than that. The legal definitions that you commonly come across are different. You may come across something to do with rape, assault by penetration, and sexual assault. So you may most likely not hear a lawyer saying something like sexual violence. They will say a sexual assault, or they may say this is defilement, this is rape, or this is assault by penetration. And when we say sexual violence, we need to know who is a perpetrator and who is a survivor. For purposes of stigma, we are going away from saying a sexual assault victim. We say a survivor, that's a person who was subjected to violence, whereas a perpetrator is someone who is believed to have carried out an immoral act. Other definitions that you're going to come across in the terms of sexual violence, you're going to come across things like sexual coercion, what is sexual harassment. For some people who may not know, but even stalking is one of the elements of sexual violence, and including also relationship violence. Now, rape, people have decided, I've asked about it in the chat. I want to clear the flow and say that defilement is not an act of sexual intercourse that is consented to. If someone consents to sexual intercourse of any form, that means it is consensual sex. That is not illegal, unless it is cross-generational sex, which is where we have concerns. However, rape is defined as the physically forced or otherwise coerced penetration of the vulva or anus with a penis or other body parts or an object. So it is not just reproductive organs, however, any other object, whether it's a stick, a metal, as long as someone physically uses that or coerces someone through the vulva or the anus, it is rape. Now, defilement goes up to a person who is less than 18 years. I hope the two definitions are obtained. In Uganda, we even go further and we add a little bit of if the consent was obtained by force or by means of threat, intimidation of any kind, or fear or bodily harm, or any false representations as to the nature of the act, then, or even if someone is married, you will then be considered to have been raped if someone does come up with that. And I want to mention a little bit about what is the legal implication if someone has been confirmed to have raped someone. It is, if it's attempted rape, it's life imprisonment, and if it is rape in itself, it's actually a death sentence according to Uganda. People need to know this, because when the law, like we've seen in the case presentation, is not respected, we let very many perpetrators move around with us and just say it is okay to bargain and have the girl child married off. It's okay to bargain and have this young boy just move around. We still have juvenile prisons where even if you're below 18, you can't be put to justice. The definitions continued. We have sexual coercion, like we talked about. Now, sexual coercion is the use of pressure or manipulation or maybe use of or misuse of power. Someone comes to you in order to get any sexual contact with you without consent. Sexual exploitation, this one when you use any attempted abuse of a position or vulnerability of power and using maybe money to approach someone in order to get to either sexually exploit them or any other benefit. Relationship violence sometimes is known as intimate partner violence when a person is in a past or a current intimate relationship. Now, this is key. Even if it's a past relationship and you are sexually involved with this person, but if they are harassing you in any form of way, it is considered as relationship violence and should be reported, because IPV, which is intimate partner violence, is one of the key things that actually is recognized in Uganda. Sexual harassment, this one includes unwelcome gestures, whether it's a touch, whether it's a wave, whether it's how you look at someone. And this is not only for girls, but also for boys as well. Now, when we look at the statistics globally, we have about 6% of violence against women. That is for people who are above 15 years. This is just global. And these statistics are actually very little because we don't speak up a lot of these. In Africa, our median prevalence is 27%, but there should be more because of what we know, the cultural aspects to this. When we look at the STBV cases or sexual gender-based violence cases that we have, most offenses most common offenses in Uganda are related to that. And 1 in 3 women are victims or survivors of sexual violence. That means in just this one room, you'll find that at least 2 people have been violated before. Sometimes we may not know that we're being violated. Sometimes we may know we are being violated. And for men, it is 1 in 6 are survivors or victims of rape or assault. So it is not just for females, it's also for men that are also involved. And 70% of people aged between 15 to 49 years have ever experienced violence or sexual or any form of physical or sexual violence. This is concerning. What risk factors do we have for someone who is a survivor of sexual violence? Sometimes people who are at risk include those living with HIV because they're usually coerced into sexual intercourse. So sometimes because of poor counseling, sometimes they say, okay, someone says, no, it's okay. I'm not going to get the disease because of this and that, or you will not get the disease because I am maybe using another form of penetration. And then history of child maltreatment. If a child grew up in a home that was not stable, they are more likely to actually experience sexual violence of any form. Any previous history of victimization or stigma, it could be a prior history, maybe a school dropout, someone who is poverty surrounding all those. And the other one is dominance and control by one partner. Now, someone can be violated if there is dominance of one partner. This can also happen if a woman is more dominant than the man in a relationship. And sometimes community and societal norms also give chance to for people to be victimized. And this is how is this? Because the people that we find in our society tend to normalize this and say if someone is assaulted, then it is okay, maybe you should just negotiate for a marriage. And a delay in justice systems worsens this process. Most times the police themselves are going to be the ones to encourage the families to discuss and say, just discuss and resolve this issue maybe with money or with marriage, but let us not waste time in the justice system because it will delay. But we shall see why. And of course, poverty through unemployment. When it comes to the perpetrators, people who tend to have multiple sexual partners or engage in transactional sex will most likely be the ones to be perpetrators. Those who have ever been involved in any violence, those who are married or cohabiting are also likely to be perpetrators. And the use of media with explicit contents is also one of the risk factors. Now, who is at risk of sexual violence? We've said that yes, anyone is at risk, but there are those groups that we usually look out for, things like children, girls, and women. But we have not said that boys are not out of the picture. So sexual violence can happen to anyone, anytime, and anywhere. And sometimes can happen in schools, in offices, in camps, or in isolated spaces, and sometimes even in the homes. When you look at medical examination of the patient, the key things that we have to go through are: one, make preparations to offer the medical care to these survivors. Is this medical care also available to any clinic? Let's say if you're in charge of a health facility, even if it's a health center too, are you able to receive this client? When if it's a clinic out there in town, are you able to actually handle this client? So always make preparations, because you never know where this victim is going to come from. Secondly, is prepare the survivor for the examination. You do not just get up and move onto a survivor and then say, I'm going to check you, and then split legs and then try that. No, prepare them and walk them through, because you examining them is actually another form of trauma. They are envisioning what just happened to them. Taking the history is key, because history will then build up onto the form, as we're going to see on the collection of the forensic evidence. And when you're collecting the forensic evidence, it is key to remember that we need to enforce community awareness and education, and even the health facilities have a role to play in this. Collecting evidence includes that when people get these any cloth or any sticks that were around the place where that violence happened, collect them and put them into a paper bag. If they do not have paper bags, they can use newspapers and drop them in there. We tend to avoid plastic materials because they do take away the chance for us to get the specimens and examine them for forensic evidence. When performing the physical and dental examination, please kindly put into consideration the privacy and the confidentiality of this person, even if they are a minor, even if they are 2 years old, even if they are neonates. They need to be protected. And a physical examination does not only involve genital examination for sexual assault. Many of the cases in the courts of law get lost because the victim's story does not match the examination on the papers. Now, most health workers rush to just go to the genitals and say, I do not see any wounds. I do not see any blood. Not every sexual assault victim is going to come to you bleeding. That's one thing you have to recognize. Not every sexual assault is going to come to you with a vaginal penetration injury. It might sometimes may be, and sometimes maybe mistrangulation, and you miss out the marks on the neck. Sometimes you miss out the marks, the bruises on the arms, because there's been struggle. So it is important for us to match the history and the examination. When someone says he forced me on the ground or she forced me on the ground and maybe held me on my wrists, check those wrists and document entirely onto the form 3A that we are going to see. Document that story, because that story, as long as the lawyers and the judge does not have the story matching up to your physical exam, there is no case. So that is why always the cases get lost, and yet the people are actually hurt. Then I know my colleagues talk about the treatments and the counselings and the follow-up of the survivor. When we look at the essential components of care after rape or any form of sexual violence, one is documentation of the injuries. We have said do not rely on only the genital examination. Please look at the physical. The story of the patient must match up to the physical examination, and do not be the judge. A healthcare worker is not there to ask where were you at this time. Your work is to attend to the client and make sure that you're able to document their story and physical examination. Treat injuries and refer where possible. If there are any anal injuries, please refer to surgeons. In this case, we see that an OB-GYN referral was made for vaginal injury, because bleeding and persistent pain should be an indication that something went wrong. There should be a penetrative injury that is extending and needs urgent repair. We need to also evaluate for STIs and offer preventive care, as was done in the case, and my colleagues will talk about all the others, and evaluate for any pregnancy and also provide pregnancy prevention. Now, when you look at the medical form for medical assault of a victim, I wanted us to just look at it, but it is accessible on the UPDF web internet pages. It has 4 pages and includes examinations for both male and female. In case someone comes to you and they are male, please can you still use this form? It's supposed to be filled by a certified healthcare practitioner, so do not wait for only a doctor. I always tell midwives, you're also certified to fill in this form. You can fill in this form if you're at a health center 3 where there is no doctor, or health center 2, and then you keep a copy or a duplicate form at your facility. These forms are accessible to the public and can be downloaded. Do not always send clients when they come to you first, to first go to the police and then come to you. please attend to the client, and you can fill in this form, and then they can go with a copy of this form to the police. You don't have to do that. And the pictogram should include all aspects. I've already emphasized on that. When you look at the front and the back of a person, you need to also establish where is the injury. Now, these pictures are not just there because they're just there, but most times when you get a medical form filled, you find that the aspect of the physical part is not filled in, and you wonder why. But then people always rush to the genital part. If you rush the genital part of this form, you have missed out the story of the patient. Where are the scratches? Where are the bruises? Where are the wounds? Where is any other pain on this client? And you're allowed to even write and indicate and also circle where you need to. There is also a form for the perpetrator. Sometimes there's someone who is accused of a serious medical or a serious case, and they need to be examined. They say, no, I did not do. There's a form 24, which you can use to examine the patient. It's also available on the internet. You both include the mental state of this person and then also the injuries that they have. Mental state is also assessed in both the forms of the victim and also of the perpetrator. So the key notes that we take from here is: one, evidence includes bite marks, saliva, hair, body fluid, blood, clothing. Do not wash the clothing, and then use of paper, a paper envelope. Now, sometimes you may be in a facility that has access to sexual assault kits. These sexual assault kits will help you to get any of these things for evidence. If it's a bite mark, kindly mark where the bite mark is. You're allowed to take photos, but with consent of the person. If it's hair, sometimes it's saliva, sometimes it's even skin that is under someone's nails. If someone says, I scratched him, you can collect that information and get a DNA profile under that. And then medicines, my colleagues will talk more about that. About emergency contraceptions, I wanted to add that we have both hormonal and then also the copper IUD. So this can be given depending on the age of the person. However, SPPs can take up to 5 days only if you're using another form, which is the ulipristal acetate. However, the other one that we usually use, the emergency pill, Plan B, those ones will take only up to 72 hours. However, if someone is of reproductive age, that is 15 and above, you can still offer them an option of a copper IUD as long as there is no harm or there is no infection. When to refer, if always inform your senior. Now, even if you're a medical officer at a health center, please inform the in charge of the facility. They need to know. And the referral points, my colleague will talk more about that, but uncontrollable bleeding and persistent pelvic pain should be an indicator for urgent referral. And there's always need for community integration and follow-up. When we look at the consequences of sexual violence, not only health, but also we have social and behavioral problems. And the behavioral problems definitely stem from a lot of mental and neurological disorders. There's depression, suicide, and sometimes the PTSD. And sometimes there's something that we call the rape cycle, the vicious cycle of rape. Someone who is raped sometimes re-victimizes and actually ends up being raped once more. And there's also isolation and low self-esteem amongst these populations of people who are violated. And we have an increase of communicable diseases, not just HIV, but other STIs as well. And when it comes to poor health, if someone ends up pregnant, they end up being either having a low quality care of their pregnancy. Sometimes they don't even attend antenatal. Sometimes they even resort to unsafe abortions in order to terminate these pregnancies. But these are all consequences of rape and can be preventable. And I want to thank you all for listening to me. I'll now carry on to my other colleagues.
Thank you very much, Dr. Babirye, for such a comprehensive overview. You've been able to tackle a number of aspects, and I believe it has laid ground for the next speakers, our next experts. If someone has a question, kindly post it in the chat. However, I have so far 4 questions for you, and then I'll give a chance to only one person who will raise up their hand, and then they will unmute to ask their question. The rest kindly type in the chat, but the first person that raised their hand will have to ask their question. Someone asked, what HIV tests do we do for babies that are less than 3 years?
So there is baby is less than 3 years, especially those less than 18 months. You can do the DNA testing for HIV. So that one is available, and then you can always refer those clients for PCR in case you're not able to do them.
Okay, thank you.
But if a baby is 18 months and above, you can still use the detamine to detect HIV.
All right, thank you. And then the one asked, I'm going to ask, I think, all the questions, then you answer them at once. What is the incidence of rape by region in Uganda?
We do not have data for that. And I hope that health workers on this platform can be able to capture that information so that we can be able to have that displayed.
Okay. And then how do you estimate the age of a survivor when filling the police form?
You want me to answer now?
I think you can first note that one down and I ask you all the rest before. And then someone asked, what is my role as a rape survivor before I come to the hospital? Am I allowed to actually finish, like I did that scene, go shower, change clothes, come to the hospital? What am I required to do as a survivor if I'm coming to the hospital for examination? You need to briefly tell us about that. Yeah. Now someone said bruises in a dark-skinned person. How do you identify those? And then also, someone asks that you really clarify and stress the point of how long does the emergency contraceptives stop working? Yes, Abdu, you asked if a nurse can also feel at level 2. That one was answered in the presentation. Yes, you can. And then the last question, are private facilities also allowed to fill this form or only government facilities? The questions are so many. Is there anyone who has their hand up for the very last question? No one. All right, so we shall briefly answer those and move on to the next presenter. Thank you.
Okay, thank you very much. So yes, number one, private clinics are allowed to fill in these forms. You're not out of the health sector, so you can access these forms and actually have them at your health facilities. Emergency pills. Someone asked how long emergency pills take to work. Depending on the type you're using, the best time for efficiency is 72 hours if you're using Postina or Plan B. If you're using the Unifristo assessment, that is up to 5 days. If you're using the copper IUD, it can take up to 7 days, not longer than that. That's the best effective time. And then someone asked about the age of the survivor. This one depends. You can use either the teeth. So you can use either teeth, that means taking x-rays of the jaw. Sometimes you can use bone age, which includes having the humeral or the femur length of the client, and sometimes only just asking what is the age in the history. Can also give you the age.
Yeah.
So the other thing is someone asked about the role of a survivor. Yeah. If you have been sexually assaulted by any form, your role is number one, do not wash up. I know women, we are self-conscious, but if you have chosen to change your clothes, carefully take off those clothes and put them in a wrapped paper. If it's a newspaper, that's okay. Wrap them in there and carry them to the health facility. Do not wash. Do not put anything in soap or in jik. Carry everything as is. Whether there is blood, do not be embarrassed, carry that. We advise that your underwear should not be removed. If it was still on during the assault, leave it on because sometimes it may carry extra hair from the perpetrator, can carry semen, can carry other samples. And then when you arrive, we request that all people should have. Your role is to also accept us to examine you. We know it is very, it's also another form of trauma to examine you, but you should be able to accept someone else to examine you. And for parents who have had assaulted children, your role is to do the same. Please bring your children before 72 hours elapse to the facility for emergency care and for treatment of any other form, and also for, of course, follow up thereafter. The other thing after that is for you to move. Unfortunately, after the health worker is able to hand you over maybe to another level of care, or sometimes they even get to lose you, we need you as a survivor to walk and get maybe to the police, a nearby community person, can be an LC1, can be someone who you trust, and inform them, and they can help you move to the next level of care, because you need justice, and justice available in Uganda for this. Thank you.
Thank you very much, Dr. Babirye. We shall move on to our next presenter, and that is Dr. Racheal Kwagala. Dr. Racheal Kwagala is an emergency medicine resident at McChurch University, and she's going to take us through the emergency management of sexual violence victims. Dr. Kwagala, you're very much welcome.
Just to confirm whether I am loud and clear.
Yes, you are. I can hear you. Thank you.
Okay. Are you able to see my screen?
Yes, we do.
Thank you so much for this opportunity. Thank you so much, the previous presenter. You've been very well elaborate, and actually you've shared most of the things that I need to talk about. And I believe they're going to be interesting. So my role here is to talk about the emergency management of a sexual violence victim. We've been told not to call them victim, but survivors. So I'll change that to call them. Hello. Yes.
Yes. We would like to know, is it comfortable for you for us to share these slides, or would you like to share them yourself? What's more comfortable for you? We continue? All right, thank you.
So we can go to another slide. So my role here is to talk about the emergency management of a sexual assaulted survivor. As you know very well, that the entry point to the hospital is the emergency department. Most of the cases, this is where the people starts from. So it's very, very important for the people working the ED to be acquainted with the clinical presentation, knowledge and skills in assisting the survivors and in managing them. So the question is, what is my role as an emergency physician in the emergency room, or a health worker in the emergency room in managing the survivors? So there are three major points here for us to note. As the previous discussant expert has elaborated, one is for us to treat and manage acute medical conditions and injuries which the survivors are going to present with. That takes precedence of anything, over reporting, over taking history, of doing your rep kit. You have to first attend to the acute illness or medical condition that the survivor is going to present with. Secondly, preserve and correct the forensic evidence. Please, as you're managing the patient, you should take into consideration to preserve the evidence, the forensic evidence. And three, giving prophylaxis for pregnancy and also sexually transmitted infection, as we shall see. And don't forget to provide psychosocial support to the survivor. So there's no textbook presentation. Patient presentation may range from no symptoms at all to hemodynamic instabilities related to traumatic injuries, could be in abdominal injuries or vaginal, perineal. I mean, it could be blunt, could be head injuries. So we are supposed to be well equipped and geared for everything. Next slide. Yes, so we are very much aware that the evaluation of any patient who comes at the emergency unit begins with assessment of ABCDE, or the patient's airway, breathing, saturation, disability, and the exposure. So us assessing the patient in an organized way help us to discover the acute life-threatening injuries that a patient can present with. So when a patient comes to you, you're going to assess the airways, the patient's airway pattern because patients can come even in unconscious state, but they are as a result of rape or sexual assault, as we talked about it. So assess your ABCD. Is the airway patent? Is the breathing clear? Do I have a good saturation, disability, and exposure? And attend to every problem that you find in any of the points before you proceed to another. So after identifying all your injuries in ABCD and addressing them, yes, some of the possible injuries that you can get could be internal injuries. I've talked about that, blunt injury, penetrating. The patient can be having altered mental status or hemodynamic instability. You can present. So you address each one as you find the injuries while you're doing your ABCD. So it's very important for us to be able to take these three important areas. 1, to recognize. 2, to record. And 3, to appropriately refer the survivors. If I told you are in a healthy facility or setting where you cannot do much for the patient. I put here recognition because, yes, not every patient that is going to walk into the ED or into your emergency room is going to say, oh, I am a case of sexual assault or sexual violence. Sometimes someone will come being escorted by the perpetrator themselves, and they are going to give you a presenting complaint that is not related at all. Maybe they'll say, I just have a headache, but you should be able and have a high acumen of understanding that maybe this is a case of sexual assault. By examining and taking your history fully, you will be able to recognize that this is a case of sexual assault, and then you help the survivor, as we've been told to call them. Second is recording. All documentation is very important because these cases are attached to the, because of the legal implication that are attached to these cases. So record appropriately all the information that you get, including your history taking and your examination, as we shall see. And lastly is referral. Referral is very important. You refer to as to link them to where they can get help, and in case where they've got multiple traumas or injuries that you cannot manage, as we saw in the first presenters, our case, that the patient needed repair of the laceration and was referred to the gynecology. So please, referral is a form of management in this case. So now when we go to history, the history is detailed. Please have time. If you are attending to many patients, please call a colleague to help you and attend to other patients, and please give time to the survivor. Actually, when they come into the ED, you're going to triage them. We don't triage them green. They might not be having symptoms they might not present with any symptoms, but we are not going to say that maybe that's a green patient. No. Because of the legal implication and then the psychological trauma, we categorize according to our Uganda triage and treatment algorithm. We triage them as yellow patients that need attention within 30 to 1 hour. So you're going 1 hour period of presentation. So you're going to give them time. Please call your other colleagues to help you with other patients and give them time. And when you start, please walk through the entire process with them, not to say, oh, okay, I've done this and let me leave you. No, please go through all the process with them. Don't leave them. So the detailed history one, it includes taking the medical history. It's very important for us to know when did this person have their last menstrual period. Record and ask the patient whether they've had any other anogenital injuries or surgeries or any diagnostic procedures or any treatment. Why? It's very important because these can affect the interpretation of your current physical findings. Take history of any pertinent medical conditions that may affect all the interpretation of your physical findings, including like blood, dichariasia, and other things. For example, if someone is having petechiae, is a petechiae due to because of the trauma that they got during the process of the assaultment, or it's because the patient has a medical illness and maybe is having low thrombocytopenia and now is bleeding. So you take all that in history, it's very important. You're going to go and take history of pre and post assault history. Like what happened before, what was it like before the assault, and then what happened also after the assault. So it's important for us to know whether the patient or the survivor, whatever patient or the survivor has had any other intercourse within the previous 5 days. Could be anal, vagina, or oral. Why? For example, just take an example. If a patient, let me say maybe he had sex at night and maybe early in the morning as she was walking to school or what, she's raped. So for you not to have, as you're going to take the semen and for examination, you should have noted that in your history. It's very important. Alcohol. We know very well that most of the sexual assault cases involve the use of drugs or alcohol. This could be either voluntarily given to the victim or could be ingestion by coercion. So it's very important to take history of alcohol use prior to assault, or whether this survivor came in with history of alcohol use between the time of presentation for examination. Next slide, please. History of assault-related history. So during the incident, did the survivor lose his our consciousness? Was there a presence of any non-genital or anal genital injury? You're supposed to note the date, the time, the location of where this incident happened, and also note the alleged assailant if the survivor knows them, the number if there were more than one, their age, their gender, ethnicity, and any relationship to the patient or to the survivor. Like in our case presentation, like this was a cousin brother. So you're supposed to note all that. You note the methods utilized for assaultment. Were there any weapons used, physical blows, restraint, burns, strangulation? Strangulation is so common. Threats of harm, or involuntarily ingestion of drugs. Yes, the history is too much, but you bear with me. So you also continue to take of assault-related. So this is here you go into detail of how the act happened. Was there vaginal penetration, anal penetration? Was there oral copulation of the genitals or anus? Was there ejaculation? Was there use of foreign body? Was there use of lubricant or not? Did they use any form of contraceptions like condom or not? You note all that. Now, yes, as the previous expert has shared, post-assault injury is very important. To some people, they don't know that after the incident has happened, you're not supposed to take a shower and change clothes. So record, as this patient has come to you, as the survivor has presented through, record the bodily functions. Was there urination, any defecation? Was there any bodily function like urination or defecation that happened? Did the survivor use any wipes or performed any douches? Did they use any removal or insertion of tapoons or diaphragms? All could be pads, not all that. ask whether the patient or the survivor had a shower, or washed, or changed clothes, or she ate or drank something, or brushed her teeth, or gargled. Record all that. If she hasn't done all that, because all those things can be scraped and swabbed and then taken for evidence. So physical exam, as my previous expert emphasized, please, privacy takes precedency. Make sure that you get a private room which has enough room, comfortable, light, and clean, and consent the patient. Don't force examination or history taking to the patient. Please consent the patient, 1 for history taking and 2 for examination. Don't, it's emphasized to us not to be human. Be human, put yourself in this person's shoes and offer the care that you would want to be given if you are in such an incident. So privacy is very important, and consent. Don't work alone. You can have someone to work with. You call another colleague to come and be with you in that room while you're taking history or examining the patient. So it's very important to do your physical examination if it's done within the 3 hours or 72 hours after the occurrence of the assault. But even if the patient is more than that, you continue to do the examination and note what you find at that point. So the role here in the emergency unit is for you to identify and document evidence of trauma, as we shall say. So we have this acronym that we use. The word is TEARS. So TEARS, it helps us to pick the important thing, where you have T for tears and tenderness. Note where there are tears and signs of tenderness, the areas that have signs of tenderness. Ecchymosis, A for abrasions, R for readiness, and S for any swelling that is identified. Yeah, so as you're doing physical exam, as I'm going to describe, you're starting from head to toe, not any form of darkness or an hygienic area. Could be in the air, could be in the fingers, you note all that. Marks all signs of abrasions in areas which are not evident to us. So like someone presenting with abrasions or ecchymosis in the back, maybe it could be as a result as is being pulled, and all that can give evidence. So we have a body map. I have a picture here where you can go, clockwise, starting from the fingers, examining the extremity, go clockwise to the head, neck, come to the other arm, go to the chest, abdomen, and then go to the lower limbs so that you don't miss out anything. So you can mark where the areas of tenderness or abrasions or noses or tears are located on the body map. If patient consent, you can take a picture, but with a patient's consent, and maybe remove the face. It's very important. Next slide, please. Yes. So in cases of strangulations, you're supposed to take more keenly to certain areas of the face and the neck and the chest. If there is any history of strangulation, please don't forget to note the patient's neurological status. Note whether there was any loss of memory, fainting, loss of consciousness, abnormal behaviors that a patient can present with as a sign of loss of enough oxygenation to the brain. Look at the eyes for petechial hemorrhages in the brain, in the eyeball, or any loss of vision, all dyspropria. Note all that. Look at the scalp for petechiae, for bald scalp, as like the patient can lose their hair strands as being pulled. So you note all that. Look at the ears, behind the ear, for the battle sign, look at trauma or hematoma behind the ear, look into the mouth, look into the face, look into the chest for marks of the fingers, hoarseness of the voice, and other changes in and other traumas in the mouth. Yeah. Your examination, please don't forget the relevant anatomy. I put this picture for us to remember the relevant genital anatomy. But however, we are not going to just rush to the genitalia. We are going through head to toe, as I've shown you in the previous slide. But as you're taking the genital examination, please note these important areas of where you can find abrasions, laceration, bleeding, tears, and all sorts. So forensic evaluation. So for forensic evaluation, you can be having a kit, might be having a kit that can help you to take the forensic exam and the specimen that is required. But even if you don't have it, you can still go ahead to take the examination. So you're going to collect the clothes and then swabs from sites of contact. Swab the mouth if there was history of kissing or oral penetration. So you're going to swab the sites of contact. You're going to swab the anal genital area. And if someone have any fluid on their body, you're going to swab all that. You're going to take the scalp and pubic hair, part of them. You're going to take the saliva. You can take whole blood, and then you can take fingernails and fingernail scrapings. They can help us, as people can be scratched and all that, to get the DNA. Laboratory work, you're going to test. Okay, some guidelines say you test routinely for all the STIs, including hepatitis, gonorrhea, chlamydia, and HIV. But in our cases, usually we test them for HIV. We don't test for other STIs, and we just institute treatment, as it has been identified that in some cases, in courts of law, the perpetrator can use the evidence of maybe if someone is having a STI that was confirmed and say that this was a promiscuous person. So we test for HIV, and then we're going to institute the prophylactic treatment. Pregnancy test, preparation, which can help us if someone is having semen. Weight preparation should be done, as it can show motile sperms. Toxicology screen, as I said, that most of the cases of sexual assault involve using of drugs and alcohol. So you do a toxicology screen to identify alcohol and other drugs that can be involved. You do a urine toxicology screen. Imaging is done based on the patient's history and symptoms that the patient is presenting with. You can choose to do abdominal ultrasound scan. If you're suspecting trauma, you can choose to do a CT scan if it's warranted, patient having head injury, and you want to rule out intracranial hemorrhage, or it might not be necessary at all. If someone is having chest trauma, you can go ahead to do a chest X-ray. So imaging is done based on the patient's history and then signs and symptoms.
All right, Dr. Kwagala, we really appreciate this presentation. I request that you try to wrap up. Our time is fast spent.
Yes, actually, I'm finishing. So the last slide, please. Yeah, so in summary, the management is going to, the management is initial resuscitation, management of injuries, giving prophylaxis, treatment, vaccination, emergency contraceptive, and then social psychosocial support. Next slide, please. So the prophylaxis for STIs, CDC recommends giving ceftriaxone 1 gram IV single dose, and then follow up with doxycycline and then metro for 10 and then 7 days. You can go to the next slide. So the emergency contraceptive, as the previous discussant said, we can give a plan B, that is levonorgestrel or combined estrogen or mifepristol or uriprestol. And I have here in the comments, like at what days them and when to stop them. They just have a higher doses of the family planning, the contraceptives that we use. Yes, the Reproductive, you can give it up to 5 days, but the rest you give up to 72 hours. And then the copper IUD, next slide, the copper IUD that can go up to, yes, they say 7 days, but it's appropriate to give it within 5 days. Next slide, please. Yeah, the guidelines for hepatitis B vaccination. In summary, I'm not going to read everything. In summary, if the survivor doesn't know their status and the perpetuator, you don't know the status of the perpetuator, and the survivor has never been vaccinated, it's very important for you to give the hepatitis B vaccination as a dose. And you give the first dose, and then you follow up with the next dose within 1 to 1 and 2 months, and then the other dose between 4 to 6 months. But if it has been known that the perpetuator was HB surface antigen positive, and the survivor has never been vaccinated, so you first give immunoglobulin and then you continue with the vaccine. And then not to forget giving tetanus if it's required. If a patient have any injuries, you give tetanus, and also, yes. And then, yeah, that's it. Hepatitis, HPV if the patient was less than 9 years, especially for girls. PEP, you're going to refer the patient and give them a PEP prophylaxis exposure, that is for HIV. And most of the health centers that we have in Uganda, they have PEP. So you refer the patient. If you have it, you give. If you don't have, you refer the patient. The last talks about who is to admit and whom do you send home. So if a patient is the survivor has injuries that warrant his admission, please admit them. If they've told you, for example, the survivor came in as a child or an adult but feels that home is not safe, please admit them, don't send them home, and involve in social work to help you till when you are assured of the security at home, then you can let them go home. However, if they insist and persist that they want to go home and then they don't have injuries that warrant his admission, and then you've linked them to a social worker who is going to help them with the legal perspective of it, you can allow them to go back home. So in summary, that has been my presentation. It's very important for us to identify the injuries and manage them, give them prophylaxis treatment, and then preserve the evidence, and then offer them social psychological support. Thank you.
Thank you very much, Dr. Kwagala, for sharing with us the emergency management of, survivors of sexual violence. All the questions that have been asked in the chat have been answered by Dr. Grace Babirye. I would like just one person who would like to ask their question to unmute and ask it. Strictly one person. If you have a very burning question, raise your hand. For Dr. Kwagala. Okay. I see that there is no one. In case you have asked a question in the chat, kindly open the chat. The responses are right in there. They've all been responded to. And I'm going to invite our next expert, and that is Ms. Racheal Wenene. She's going to be talking to us about the comprehensive approach to sexual violence victims. And mostly, I think it will be, the the legal approach, since you have been listening to the medical approach. Thank you.
Okay. Thank you, everyone. Good afternoon, everyone. I'm Racheal Wenene, SRH expert, Women First Victor and Autonomy Health Initiative. So, because of the differences that we're coming in managing sexual violence survivors, the World Health Organization and the United Nations Office of Crime and Drug came up with an approach or a toolkit to help in the management of sexual violence. So they came up with a framework that is called the Survivor-Centered Approach to Sexual Violence. So what is a survivor-centered approach to sexual violence? When you have a sexual violence survivor, there will be two scenarios that happen. The survivor will report to police first, or the survivor will seek medical attention first. So in case the survivor goes to police first, what happens? The survivor will report to police, and the police will give the survivor a police form 3 that Dr. Grace already emphasized on. So after the survivor gets a police form 3, they will be referred to a health facility for medical attention. In other scenarios, you find that the police has a facility attached to it. So if the police has a facility already attached to it, that means that the survivor will receive medical attention from the police facility or hospital. So in cases where the survivor goes to seek medical attention first, what happens? Now, in such scenarios, what happens? You, the medical personnel, you need to attend to the needs of the survivor. Please do not send the survivor away to go back to the police. No, that will not be right. You have to respect the choices, the rights, and the decisions of the survivor. If they have come to you first, make sure you attend to them. They should receive treatment, care, and counseling. As we all know, sexual violence is an experience that should not happen to anyone. None of us deserves to be a victim of sexual violence. So put yourself in the shoes, put yourself in the position of that survivor. If it were you and you're undergoing such a scenario, would you want to go to a facility and then you're sent back to police first? Not of course. If the survivor has trusted the health facilities to be their entry points into service, into getting service, then please endeavor that you're able to support the survivor to get the required service. So what happens when the survivor comes to you, the health personnel, you give the necessary care and treatment, and then the survivor decides whether they can continue to police. Your role as a health professional is to give the right information to the survivor. And the survivor has a right to decide on what is next for them. So the World Health Organization still went ahead to come up with key principles while handling sexual violence cases. What are these key principles? Remember, this is medical legal. So because this has a legal aspect on it, we kindly request healthcare providers to be very keen. Please be very keen. One of them is respect of autonomy. Provide accurate information. Give accurate information to meet the needs of the survivor. And then after giving accurate information, for every step of examination, please let the survivor consent. If there is no consent being done, things will turn around for you as well. This is a legal thing. So let's be a little bit careful. Do not fear to support the survivor, but make sure you're giving the right information to this person, and then consent should be done. There's also access to services. Any medical needs of the survivor should be addressed immediately. This is where the STI management comes in, the emergency contraception comes in, the HIV PEP comes in. So please don't send away a survivor before attending to their urgent medical needs. Then the other key principle that World Health Organization emphasizes is the right to confidentiality. The survivor has a right to be examined in a safe, secure, private space, and still has the right to choose who to work on them. If the survivor is a female, she may decide that I don't want to be worked on by a male person. Please try to be patient with them, explain to them the need, why examination should be done if you don't have maybe a female. But ideally, when you're examining a female, there should be another female person within the room. So please explain to the survivor, and then consent is key. Make sure the survivor has consented. Another key principle is non-discrimination. In the chat, there have been a lot of questions on sexuality and gender orientation and all that. So World Health Organization emphasizes there shouldn't be any discrimination regardless of religion, race, sex, gender identity, age,
what's your take on what should be done?
Profession, economic level,
especially those that present
political affiliation, sexual orientation, or any other. So do not discriminate on survivors based on anything. So the key points when managing issues in sexual assault are quite almost the same. Just to emphasize, there should be informed consent. That one is a must for all the steps of medical examination. Please let the survivor consent. Then documentation, like Dr. Grace and Dr. Kwagala emphasized on documentation. If you do not document your findings well, then you're putting this survivor at a risk of losing, like the case if they're going to the legal bits. Please document whatever examination you've done, document. Remember to use the language of the survivor. Let the survivor not tell you another. Let's endeavor to document. Then another key point is managing risks of pregnancy. Make sure you've done baseline testing or you take history to make sure the survivor is not pregnant before you give the emergency contraception. Otherwise, if you give emergency contraception to someone who's already pregnant, then there's no need for that. HIV testing, you still assess and do baseline testing. You don't want to give a PEP to a person who's already on ACT. So make sure, or you should know the status of the survivor. We don't want to say the survivor was negative and yet they were already positive. So these are legal things. Make sure you are documenting every sort of the way. Then management of other STIs. Dr. Kwagala already talked about the treatments that need to be given for STIs. So please make sure you're managing STIs of the survivor. Then there's also wound care. In case of strangulation or any wounds on the survivor, please examine, document, provide antibiotics and tetanus prophylaxis. So so currently in Uganda, what is happening? If there is a scenario of sexual violence, most people do not know what to do. Currently, I hope we are all aware. If we are not, there is a toll-free number established by the Ministry of Gender and Labor in partnership with UNICEF for children, women, and men who have experienced abuse. So the number is Sauti 116. You do not have to write the word Sauti while calling. You just dial 116 and then you'll get connected to a counselor. This number is available 24/7. So all the time there's a counselor on the line. You can even try that number after this. You try out and that number is always available. They will connect you to a counselor. The counselor will take you through the steps of what needs to be done. In case you're seeking for a center closest to you for support, they will still do that. They will connect you to the nearby center that can support victims of sexual violence. So please let's note that number. Don't be stranded and you don't know what is next. Then also the Uganda Police has a gender-based violence toll-free helpline. The number is displayed there. So whenever you have those two numbers, at least, you can reach out to them anytime. They will be able to connect you to the nearest center to support. Other organizations in Uganda that support survivors are Uganet and then the Center for Domestic Violence Prevention. But the agents who are Sauti and the ones that are very necessary for all of us to know.
So let me first talk to him.
All right, thank you very much, Ms. Wenene, and excellent timekeeping. Yes, exactly within time. Well done. I'm going to give a chance to one person having a burning question in regards to the presentation Ms. Wenene has just made, especially legal aspect, because it was concerning the legalities of sexual violence. Someone to raise their hand and unmute and ask that one burning question. Yes, Agnes Manahe.
Thank you for the in line with just the recent presentation on legal issues, there is a question that I would like to get clarification on. The time I got this victim who wanted a very young child, and this person, they were deep in the village. And when I tried to see that this client gets the justice or gets the help, it became very hard because where I was, there was no clear way on how to really handle these issues. We took the case to police, and the local police really didn't take it as a serious case. Then we went ahead and I tried to follow up with some organizations that could help this young girl. And they kept, trying to say, we're no longer serving that community, we're no longer serving that district. So as I really looked at it as these service, like people who can help, were not within reach. And then I got someone who was in Kampala and was really willing to help, but then she was like, that is very far, we still don't serve there. Then in my heart, I was like, since it's within Uganda, is there a way that if the victim is in one district and this victim cannot access justice in that district due to the issues that may be within that district, is there a way this person can be helped from top, maybe can even go to Kampala if this person is deep in the village and gets the justice or the services, other than, saying these issues should go through the local way, first maybe the LOC, second to the police, then maybe to court, and later on people give up, because at one point these clients gave up. They didn't get the justice. So how best can we be helped that as this toll-free number has been shared, can we get this access? Like if I call and I need the support, this person will not maybe say, you first go down, do the follow-up, because most of these rape victims are—
All right. All right, thank you very much. Your question has been captured and it will be answered.
Okay, thank you for that question. Now, currently what happens with Sauti 116 is when you call, you get connected to a counselor and there's a follow-up from the ground level up to when justice is got. So what we advise currently for even in far-reach areas that are far away from Kampala, please just call the number. They will connect you to a counselor and then attach someone to follow up that case. So UNICEF and Ministry of Gender currently they have, I'll call them like regional bases which can handle gender and violence related issues. So they will attach someone to follow up that case. Please do not hesitate to call. No matter what part of the country you're on, call Sauti 116. Please do call. They'll do a follow up.
All right. Thank you very much, Ms. Wenene, such a wonderful presentation. Unfortunately, due to time, we cannot take another question. In case you still have questions, kindly just post them in the chat. They'll be answered right in the chat. I see that we had another hand up. Apologies, we won't be able to take those up, but text the questions in the chat. Thank you. We shall move on to our next presentation. We have been able to listen to the medical aspect and also the legal aspect of managing cases of sexual violence. Now, there's that unseen effect or consequence of sexual violence that rarely is talked about or given attention, and that is the psychological bit of it. The trauma it actually causes to the survivors. And amidst us, we have Miss Joy Gumikiriza Onoria, who is going to take us through the psychosocial support to victims. You're very much welcome, Ms. Gumikiriza. We request that if you're able, kindly switch on your video and please take on the floor. Thank you.
My video is on. Good afternoon.
Good afternoon to you.
Are you sharing from your ends or should I share from my side?
Well, are you comfortable with us sharing?
Yeah, sure.
Okay, great. We can see your video and also the slides are projected.
Okay, thank you very much. So we have all listened. This has been a very, very engaging talk. And I believe most of what I would have wanted to add or say has been alluded to. So I will go directly into what I feel are the psychosocial issues that we're going to be discussing. Please take us to the next slide. And the next slide, please. All right. So trauma and sexual violence, like we have really had widespread issues, and they impact very many people, millions of people globally, but also in our country. The sexual violence and trauma, they have significant psychological effects. Earlier on, we saw that they predispose someone to developing post-traumatic stress disorder, depression, anxiety. They affect the physical health of the person. For example, you'll notice injuries and chronic health issues. They have social consequences like stigma, social withdrawal. There's also an economic impact that these sexual violence and trauma issues have on everyone, including the governments, like loss of productivity and medical expenses. So we have seen the studies have shown that people who have experienced trauma are 4 times more likely to become alcoholics, that is, abuse alcohol. They are 4 times more likely to develop sexually transmitted diseases, HIV, venereal diseases, STIs. They are 4 times more likely to start using drugs like injection drug users. They are 3 times more likely to use antidepressant medication, but they're also 3 times more likely to be absent from work, from school, and also socially withdraw from their friends. They are 15 times more likely to commit suicide. This is quite appalling. They are 2.5 times more likely to smoke tobacco, 3 times more likely to have serious job problems or school-related problems, and they're also 3 times more likely to develop depression. So with these statistics at the back of our minds, let's just go back a little bit. With these statistics at the back of our mind, we lay a ground for us to be aware that sexual violence, yes, we have seen the physical, we've seen the medical component, but it has significant impacts on an individual's psychological and social outcomes, like we've seen. Next slide, please. So when we talk about psychological or psychosocial support, we are referring to the assistance provided to individuals and communities to promote their mental health and social well-being. So in this particular category, we are not only focusing on the individual, but we are looking at, you know, one famous psychologist called Gestalt says the focusing on one aspect is not enough. So you would rather look at the totality or the sum of the parts of who you're looking at. So an individual is not separate from their society. They come from a family, they come from a community, they come from a school, they come from many things that make them who they are. So this psychosocial support is going to look at activities that are going to support the individual, and we'll look at things like play and art. We're going to reinforce the social and emotional learning of the individual. We're going to foster learning and resilience of those who have been affected. And then we also ultimately want them to recover from the impacts of the disasters and or any emergency that has taken place. Next slide, please. So then what are the components of the social support or psychosocial support that we offer trauma and sexual violence victims? We have the emotional support. And emotional support involves providing empathy, understanding, and encouragement. We saw the significant impact that the trauma and the sexual violence has on the individual or on the survivor. So this trauma is going to cause a lot of emotional disturbances. And these then, you have to be very empathic, you have to be very understanding, you also have to be very encouraging. Don't assume that you know what this person is going through. So I know usually many times we tell people, oh, I understand, I feel you, I hear you. We don't know what they're going through, but we can offer the empathy and walk with them this journey for them to be able to overcome the emotional turbulence that they are experiencing. So it involves active listening, engaging attentively with the individual to understand their feelings and perspectives. One of the previous speakers mentioned it is not your role to find out, to ask questions like, where were you at this point? In this particular point, it's in this particular time, it is your role now to just listen, understand the feelings and the perspectives of this individual. We also provide comfort and reassurance and offer words of encouragement and empathy to help them feel supported. Usually by the time they come to you, they have gone through a lot of self-criticism, self-blame. They feel they were to blame in the first place on many things. And you know the stigma that is around the violence that has happened to them. So we want them to feel encouraged, offer words of encouragement. But then we also use a lot of peer support groups to facilitate this individual to be able to share and see other survivors who have been able to overcome. So that's what we do in the emotional support. Oh, next slide, please. Sorry, I thought as I want to change the slides. So we also have the psychological counseling. Many have talked about counseling. Call the helpline, call Sauti, they'll offer some counseling. In most cases, they're doing psychological first aid, which is a form of counseling. And it involves therapeutic interventions that are aimed at helping the individual cope with the psychological aftermath of their experiences. So what do we do during psychological counseling? We do individualized therapy. We do the psychological first aid. At that point in time, we're giving an individual a possibility to debrief. When they debrief, they're able to, you know, the saying that goes, a problem shared is a problem half solved. So when you debrief and find out that there's help out there and also be linked to the places where you can get support, then you're starting the journey of healing. So now the specialized psychological counseling is going to focus on the individual one-on-one sessions where we'll have trained therapists, counselors, clinical psychologists, psychiatrists who are going to come and look at the personal issues and develop coping mechanisms for this particular survivor. The psychological counseling also includes group therapy. These are facilitated sessions where survivors can share experiences and then they support each other under professional guidance. It also focuses on specialized trauma-focused therapies, for example, cognitive behavior therapy, the EMDR, which is the eye movement desensitization and reprocessing. And these are specifically designed for trauma, and they help the individual process the trauma and learn how to cope with this trauma as they let go of the emotional turbulence that was caused. Next slide, please. It also includes social and community support. And this involves collective efforts like we had earlier to create a supportive environment for victims of trauma and sexual violence. So here we use support groups, we use community awareness, and we also use collaboration with local organizations. For example, working with NGOs, looking for specific community groups like we're going to see later, and work with the service providers, different service providers, including the legal team. I'm happy that we've been able to talk about to address the legal aspects as well. But you look at the legal aid, the medical services available, but in many cases, we also need to think about the financial assistance. You as the individual who is the first person that is being approached might not have the funds to do this, but maybe there are people that we can call or communities we can reach out to who could be very helpful in supporting this kind of activity. Next slide, please. So then in Uganda, what is available? The previous speaker alluded to some of these things, the Sauti, the police. So we have government programs like the gender-based violence shelters and one-stop centers that are offering this kind of medical care, the legal aid, and the psychological support. For example, the Center for Domestic Violence and Prevention. We also have the Women's Protection Center, Action Aid Uganda, and usually these different people or these different partners, they work together with the Ministry of Gender, Labor, and Social Development. There are also NGOs. For example, the FIDA, the Uganda Association for Women Lawyers, also offers some kind of legal support to survivors of sexual violence. Action Aid and Raising Voices. I believe we've seen the adverts of Raising Voices running. They also provide some legal aid, counseling, and advocacy, and they run community education and awareness programs to combat stigma and promote gender equality. We have also seen some community-based initiatives, which are really crucial in both remote and rural areas where we might not have formal services or the formal services are limited. One of the participants asked a question: what happens when I call and they're all in Kampala and they cannot reach me where I am at? I was happy that my colleague was able to allude to that, but you can also reach the local leaders and volunteers because some of them provide support and referral services within your community. So the programs like SASA, which was developed by the Raising Voices, it aims to change community attitudes towards gender-based violence and also empowers women and girls. There should be other things that are available for men and the boy child as well. Next slide, please. So then what are some of the challenges that we are still facing as a country? There's limited access to health facilities, legal aid and counseling, due to the geographical barriers and of course inadequate infrastructure. There's also this lack of access leaves many victims without the necessary support. We have seen cultural and society barriers. Many of you were commenting, posting and commenting that what happens if the parent or the patient themselves do not want me to do anything, to follow the right route. Of course, there's a lot of stigma and shame, and this has a significant impediment, significant impediment on how we seek support, but also on how we follow up for legal redress. Traditional beliefs and gender norms, they often blame victims, and we've seen this, where they say, she put on very enticingly, she spoke to me in a certain way. So these also affect the health-seeking behavior and legal support seeking of the victims or the survivors of sexual violence. We also have limited resources. Many of our people are living below the poverty line. So limited resources and also limited funding from our governments, they provide constraints to the few shelters or the few things that have been put in place to support the survivors of sexual violence. Next slide, please. So in conclusion, the fight against sexual violence and trauma requires sustained efforts and robust collaboration among the government bodies, among NGOs, among community leaders and international organizations. And when we continue to strengthen support mechanisms, we address the cultural and society barriers and ensure adequate resources, then we can create a safer and more supportive environment for the survivors. Together, we can make significant strides towards eradicating gender-based violence, sexual violence, and fostering resilience and recovery in our communities. Thank you very much for listening.
Thank you very much, Ms. Gumikiriza, for your wonderful presentation. And also thank you for keeping time. You have kept time. In fact, you have utilized less than the time that was allocated. That's very excellent. Thank you. I don't see questions in the chat, but I'm going to request someone who has a question, a burning question regarding the psychosocial support or care for survivors of sexual violence to kindly raise your hand. And you will unmute, but I've seen one hand, just a minute. I see that many of us are asking about the CPD link. The CPD link has just been posted just now. Kindly tap it and register for your CPD points. Also, we are going to have the post-test posted just in a few seconds. Kindly help us and fill in the post-test. We would like to know if this session has made any change anyways. It's been a lot of time we have spent here. There was a question directed to Ms. Joy Gumikiriza, that of these organizations you have mentioned, which ones or which others do you know that offer free psychotherapy and counseling to survivors of sexual violence? Specific ones that are offering totally free therapy. And I saw that we have someone in the chat with their hand up. I will let them ask their question and then you answer at once. Kindly utilize the links that are in the chat to register for CPD points and also do the post-test. MakCHS, you have your hand up. Kindly unmute and ask the question.
Many thanks to the presenters. They have really given an elaborate discussion and presentation in regards to this topic. For the previous presenter, talked about engagement of the local leaders in case you are not able to reach, in case you are not able to get services in the designated places. But our experience in this has always been that the community leaders, some local leaders, call them local leaders, most of the times tend to, in fact, to protect the perpetrators of these forms of violence. Therefore, my question is it really appropriate that any local leader can be involved in such kind of issues? Because most of the times they protect the perpetrator of this kind of violence. So thank you so much.
All right, thank you very much, Kawesa. I believe Ms. Gumikiriza has had your question, and I will hand over to her to answer the two questions that have been asked.
Okay, thank you very much for your question. Let me start with the last question. So we also need to use a lot of judgment here, because some of our local leaders, and please don't quote me, but some of them might actually be perpetrators, or they might aid the perpetrators. So you want to be very cautious and know the system so that you don't again get the survivor victim. So get the survivor from the pan to the fire. So we need to use a lot of caution, exercise caution, and also be very attentive to what is around us in the communities. So for the second question about places that can offer free support, I don't know whether you've heard about SCTV, which is the African Center for Treatment and Rehabilitation of Torture Victims. It does a good job. So if you can reach out to them at their different centers, they'll be able to help. Even the feeder, if you reach out to them, they should be able to help. I believe if you also went to the police stations, the police posts, they have different organizations that are attached to them. So as you follow the process, don't forget to also go to your local police post, because they will be able to guide you to those that are directly linked to those particular police posts. Thank you.
Thank you very much. Please, I request that you tap the link, register for the CPD points, but also kindly participate in the post test. It's ongoing. The poll is on. Please participate. Thank you very much, Ms. Gumikiriza, and all our experts that have made time today. We understand that you have very busy schedules. Thank you for creating that time and availing yourself to educate us. We appreciate. And we have our country director with us. And I would like to be honored to have her give the closing remarks for this session. Ms. Irene Atire, you're very much welcome.
Thank you so much, Lillian. And also thank you to our experts. Really, I know there's a lot that goes into the preparations for these sessions. I've also learned a lot, how to examine a victim or a survivor. I've also learned that we shouldn't call these people victims, but rather survivors. So really to thank you, as Global Health and the Ministry of Health, we are really, really appreciative of all the effort you put in. And again, to our participants, I would also thank you for sparing all this time. I hope that you're learning and this will change the way we manage. People who come to us for all sorts of emergencies, including sexual violence, we've seen that it's really, really highly prevalent. So let's not give painkillers and send them to our will. There's something that you can do. I hope we shall be able to revisit the slides and see how we can manage our patients better. And also to remember that sexual violence is not only for girls and women. Men, boys, all of us are at risk. So let us really take care of our people that have been entrusted to us. Thank you, and to the team that makes the preparations, thank you so much. I wish you all a nice weekend and a nice evening. Thank you.
Thank you so much. Let's not forget, kindly, I request all of us to turn on our videos. Please turn on your video and we take a picture for this session. Turn on your video so that we can take a picture, all of us together. We have a general assessment ongoing. We want to know how you have your experience of this session. Please take time, the only few questions, respond. How have you found this session? And as you do that, prepare to turn on your video, please, so that we can take a picture together. However, I love the energy. Yes, Adrian, we see you. Thank you all for turning on the videos. Please, let's all turn on the video so we can take a picture. Unfortunately, because of time, I see that we have hands up. We are unable to take on these questions.
They can send in the echo.
We have the echo group. You could share the questions in the echo group. Please turn on your videos. Are we ready? You need to stop the share screen. All right, all our videos on. All our videos on. Yeah, please let's smile. All are looking amazing. Are we taking?
Yeah, we are taking some.
We are taking the picture. No, we have not disabled. We have not disabled the videos. We can see all of you. We can see all of you and we are taking the pictures. Thank you so much for attending and staying this long up the end of the session. We appreciate and we value your time. We can see some of you waving us bye. Yes, bye-bye. Yes. Dr. Kemirembe, we can see. Thank you for smiling for the camera. Dr. Legend. We see all of you. Yes, yes. Done? Okay. We have taken enough pictures. Thank you all and have an amazing weekend. Until the next session, see you. Bye-bye. Bye-bye.
What's in the book?